Hi, and welcome to Module 2, which covers Insurance 101. This is the second module in the BDAP 101 training. In this module, we will be reviewing the BDAP and insurance coordination. Before we begin, one note to make of clarity is that the Ryan White / the BDAP is not insurance. The Ryan White program and its AIDS Drug Assistance Program, or ADAP, provide services to people living with HIV whose health insurance doesn't provide all the HIV care and medication they need. The program also provides HIV care and medication to people who are not eligible for health insurance. However, being enrolled in Ryan White or the BDAP is not necessarily considered insurance. As we begin Module 2, I would invite you to think about where we get health insurance. In our experience, you get health insurance through one of three avenues. The first avenue is through the government. The government provides health insurance through programs like Medicaid or Medicare. Or you can receive health insurance through your employer as part of your benefits package, so your job may offer you health care coverage. And the third option is directly from health insurance companies. Since the Affordable Care Act, people may purchase health insurance for themselves or their families. I invite you to click on the YouTube link here titled How to Get Health Insurance for more information about how to obtain health insurance in the United States. Throughout your work with the BDAP, we will be using these health insurance terms quite a lot. When we refer to a premium, we're referring to the monthly amount for the cost of healthcare coverage. When we say copay, we're referring to a fixed dollar amount that you pay for covered services. When we say coinsurance, this is a fixed percentage the insured person pays for covered services. A deductible is the amount that you pay for covered healthcare services before your insurance plan starts to pay. And your out-of-pocket maximum is the most you can expect to pay in a plan year. Once this amount is reached, insurance covers 100% of covered services costs. On this link here for healthcare term basics, I invite you to watch the YouTube video that explains these healthcare term basics more in detail. How you and your insurer share costs can be very confusing. So let's look at an example. Let's take Jane here. Jane's enrolled in a health insurance plan through her employer. Her coverage period begins January 1st and ends on December 31st. Her plan deductible is $1,500. She has a co-insurance expectation of 20%, and her out-of-pocket limit is $5,000 for the plan year. So let's say that Jane hasn't reached her $1,500 deductible yet. She goes to the doctor for the first time this plan year. Let's say it's in January. Her plan is not going to pay any of the costs. Her office visit would cost $125, so Jane is responsible for the full $125, and her plan would pay $0 at this point. Let's say a few more months goes by and Jane sees a couple more doctors. She fills some prescriptions. She has a couple procedures done. In this case, Jane has reached her $1,500 deductible, which is when her co-insurance cost sharing would begin. So Jane has seen a doctor. She's paid $1,500 in total. So her plan is going to pay some of the costs for her next visit. Let's say her office visit costs $75. Jane is responsible for 20% of that $75, which makes her portion $15. Her plan will then pay the remaining 80% of that balance, or $60. Let's say that's the middle of the summer, and Jane has a couple more hospital visits. Perhaps she's broken her arm and has to have another surgery and more prescriptions filled. At this point, Jane has reached her $5,000 out-of-pocket limit. She's seen the doctor often and paid that $5,000 in total. So her plan now pays the full cost of her covered healthcare services for the rest of the year. So let's say her office visit with the surgeon is $200. Jane would be responsible for $0, and her plan would then pay the $200 responsibility to the doctor. Now I invite you to visit the following YouTube link where they will cover Insurance 101 in more detail at a glance. Part of talking about those health insurance terms is also talking about medication terms. So on this slide, we're going to be reviewing some of the various terms you may hear us use in your work with the BDAP. The first is over-the-counter meds. These are medications that do not need a prescription. You can simply just go buy at your local Walgreens or CVS. These are things that are not usually covered by insurance. So if your doctor tells you to take Tylenol or ibuprofen, most of the time you're going to have to purchase that over the counter. A prescription, which is often abbreviated RX, requires that a doctor or other licensed professional writes a prescription to be able to fill the medications. Prescriptions have a certain amount of time or number of fills before they run out. If your doctor prescribes you a brand name medication, this medication tends to be more expensive because the lab that created or discovered that medication receives a patent that lasts for a certain amount of time. But once that patent expires, anyone can use the ingredient to make the drug, lowering the cost significantly. And those drugs are referred to as generic prescription drugs. And of course, to make things even a little more complicated, is the pricing level of drugs. So there is a tiering system that most insurance companies use to steer clients towards medications that will be more cost effective for the insurance company. So in this case, most insurance companies will have a formulary. And we talked about our BDAP formulary, but now we're talking about the insurance company's formulary, which is a list of covered drugs. The insurance company creates this list to steer clients towards medication that are more cost effective for that insurance company. So for example, if you were prescribed a medication for your hypertension or your high blood pressure, and your insurance or your provider says you can take drug A, and that is a drug that's on the formulary, it's covered, and you'll have a $20 copay, or drug B, which is not on the formulary, it's not covered, and you have to pay the full cost, most times you or your client would pick to pay for the covered drug versus paying for the non-covered drug. Occasionally, the insurance company may require what we call a prior authorization or a PA. This is an explanation from the provider why the medication is needed. So some examples of when this could be required are if a client is prescribed a brand name drug when a generic is available, the drug is not on the plan's formulary, so it is not covered. A different, more cost-effective treatment option could be available. A drug may also have dangerous side effects or could be dangerous when combined with other drugs, or if a drug is considered being prescribed for cosmetic purposes, or it is not preventative and it's treating something non-life-threatening. In these cases, your provider will turn in the prior authorization paperwork to the insurance company who makes the determination. If a prior authorization is approved, it may only last a certain amount of time so that alternate treatment can be prescribed. Additionally, we can consider overriding a prior authorization on a case-by-case basis. And what I mean by this is that we will often allow somebody to fill using our medication assistance program while a prior authorization is being considered.